When you look at the sheer weight of global health problems, certain diseases just stand out as titans, these monumental challenges on their own.
Right.
But today, we are diving into a really startling and, frankly, dangerous intersection. Hepatitis C virus, or HCV, colliding directly with type 2 diabetes mellitus, T2DM.
And this isn't just, a coincidence. It's not about two common diseases happening in the same person.
No, it seems to be about a viral infection that is actively driving a metabolic disease. To understand this, we've synthesized a massive systematic review and meta-analysis from 2018.
It's a huge data set. We're talking about findings from 40 different studies.
And it involved nearly 15,000 participants from all over the world.
So our goal here is to really cut through all of that noise, all those statistics, and find the unified global estimate. How often does this happen? And maybe more importantly, why? What's the biological link, and what does it mean for health policy?
Okay, let's unpack this.
I think before we even link them, it's worth taking a second to appreciate just how serious each of these diseases is on its own.
Absolutely. Two massive health crises.
Exactly. Start with diabetes mellitus. It is the leading cause of death worldwide. It's responsible for about 8.4% of all-cause mortality.
And that number is going up, not down.
It is. Predictions suggest that by 2040, the prevalence among adults will climb to 10.4%. And we all know the cost: cardiovascular disease, stroke, kidney failure. It's just devastating.
And then on the other side of the coin, you've got HCV, a much quieter, sort of long-term destroyer.
That's a great way to put it. HCV is this massive global threat. It infects somewhere between, 150 and 200 million people.
Wow.
And every single year, another 1.75 million people are newly infected. For most of them, it becomes this chronic, lifelong infection that just slowly leads to progressive liver damage, cirrhosis, and potentially liver cancer.
And it's so important to repeat what the source material reminds us of. There is no preventative vaccine. There's no post-exposure prophylaxis for HCV yet.
Not yet, so we're stuck managing it after the fact, not preventing it easily.
Which brings us right back to this deep dive. The researchers had a very clear question, right? When you pool all these thousands of global outcomes, what is the real number?
Yeah, what is the estimated global pooled prevalence of T2DM among patients who are already dealing with HCV?
And the number they landed on is, it's pretty significant.
It really is. The core finding of the whole analysis is that the global pooled prevalence of type 2 diabetes among HCV-infected patients is 19.67%.
19.67%.
And that number is solid. It has a 95% confidence interval, from about 17.25% to 22.09%.
So that's nearly 1 in 5 people with HCV also battling T2DM.
Yeah.
But what does that really tell us about the link itself? Because, before this meta-analysis, the studies were all over the place, weren't they?
Oh, completely. The researchers noted that some individual studies reported rates as low as 7.4%, and others went all the way up to 43.2%.
That's a huge range. So how confident can we be in this unified 19.67% average if the raw data was that chaotic?
Well, that's really the power of a meta-analysis, especially one this big. By pooling all that data, they can kind of smooth out the inconsistencies and find a much more reliable estimate than any single study could provide.
Okay, so 19.67% is the number we can trust.
Yes. And when you hold that number up against the global prevalence of diabetes in the general population, which is about 8.5%.
Then the implication just becomes incredibly stark.
It becomes a mandate for policy change. The research is explicit about this. The rate is considerably higher. Having HCV essentially more than doubles your global odds of also developing T2DM.
Which suggests the virus isn't just some bystander. It's a powerful driver of this metabolic disease.
Exactly.
Here's where it gets really interesting. Why? Why would this specific virus, one that we know targets the liver, be so strongly linked to a metabolic disorder that's all about processing sugar?
Right. We have to move beyond just the statistical overlap and look at what the virus is actually doing inside our cells.
And it gets pretty fascinating at that molecular level.
It really does. So the source material outlines several hypothesized biological mechanisms. The most important connection seems to be that HCV infection fundamentally alters the way the host's body metabolizes glucose, and it does this through the innate immune response.
So our body's own defense system, in the process of fighting the virus, starts messing with the way we handle sugar.
Precisely. You get these changes in carbohydrate metabolism and, crucially, in hepatic lipid metabolism. That's how the liver is handling fats and sugars. But there's an even more specific hypothesis.
Okay.
It points the finger directly at a specific part of the virus, the HCV core protein.
That sounds like one of the main building blocks of the virus.
It is, and researchers think that the expression of this core protein is what induces something called hepatic insulin resistance.
Which basically means the liver stops listening to insulin, right?
Exactly. You could think of the virus as putting up this massive electronic roadblock. It prevents the liver from getting insulin signal.
So insulin is knocking on the door, telling the liver to store glucose, but the virus's core protein has essentially jammed the lock. The liver can't respond, and so sugar just starts building up in the blood. Is that more or less what's happening?
That's a brilliant way to put it. The source suggests the viral protein directly interferes with the insulin receptor substrate signaling pathway. It's just jamming the communication line.
And the result is this chronic systemic insulin resistance that's being driven directly by the virus itself.
Correct. But the researchers also, they took care to mention that it's not only the virus.
Ah, okay. There are other compounding factors.
Absolutely. You can't ignore the social determinants of health. Things like poor management of the existing HCV infection. I mean, if the virus is left untreated, it just keeps jamming that signal.
Right. And things like low access to healthcare in general.
And then all the classic behavioral risk factors, high blood pressure, high cholesterol, lack of physical activity, weight gain, all of those things just make the problem worse.
Those compounding factors become really essential context when we move from that global average of 19.67% to the geographical breakdown. Because this risk doesn't manifest the same way everywhere, does it?
Not at all. And this is what the subgroup analysis tells us. The answer is a resounding no. The geographical variation is maybe the most striking takeaway from a policy perspective. There's a huge continental divide.
Okay, so give us the breakdown. Where is it highest and where is it lowest?
So Africa topped the list. The highest pooled prevalence rate was 27.72%.
Wow.
Asia followed at 20.73%. North America was next at 16.64%. And Europe actually showed the lowest pooled prevalence of T2DM among HCV patients at 15.02%.
27% versus 15%. That is a massive gap. We're talking nearly double the rate in Africa compared to Europe for patients with the exact same viral infection.
It's huge.
So does the source material suggest this is mainly, a difference in genetics or ethnicity, or is something else driving this disparity?
The researchers point primarily to systemic factors, not biological ones. I mean, they mention differences in ethnicity and study populations, but the crucial factors they highlight are things like variations in access to healthcare, in early HCV screening and diagnosis, and just the overall effectiveness of management strategies across different continents.
Which makes that finding for Africa, the 27.72%, especially disturbing.
It does. The source notes that Africa already has the highest WHO estimated regional prevalence of HCV infection at 5.3%. So you're starting from a higher baseline.
And then you add in the other challenges.
Then you factor in the significant challenges in the availability and use of effective HCV treatment. People are just living with that virus, with that core protein for longer, so the complication rate soars. The researchers actually use the word fueling, that poor management is fueling these complications, specifically T2DM.
So what does this all mean? The global number, the 19.67%, confirms there's a real viral link, and the geographical data seems to imply that the severity of this is heavily influenced by the health system a patient finds themselves in.
Precisely. The main conclusion for policymakers, for healthcare systems, is that HCV-infected patients are at a significantly elevated risk of T2DM everywhere. I mean, even in Europe, where it's lowest, you're comparing 15.02% to 8.5% in the general population. The risk is always there.
But the worst outcomes are highly localized.
Highly localized.
And that has to translate into a call for action that goes beyond just managing diabetes symptoms. The source seems to mandate early intervention.
It does. It has to focus on the root cause.
So what's the practical takeaway?
The practical takeaway is that the prevention and the early treatment of the HCV infection itself has to be prioritized. We have to see it as a strategy to prevent T2DM. If you get rid of the viral trigger, you get rid of the key biological mechanism driving this whole metabolic breakdown.
So treating HCV is now, you could say, a dual-purpose health strategy.
Emphatically, yes. This review really gives us a clear picture. HCV isn't just an infection. It's an active contributor to the rising global burden of type 2 diabetes.
It's forcing us to view a chronic viral illness through the lens of metabolic health.
It is. It highlights that we can no longer afford to treat these conditions in their own little silos. The body's systems are all interconnected. A single virus can have these devastating downstream effects on what seem like totally unrelated systems, like sugar metabolism.
And as a final thought for you to consider, just look back at that continental data.
Yeah.
That ranged from 15.02% in Europe all the way up to 27.72% in Africa. The question you should be asking yourself is this: how much of that 12-point gap is really about some inherent biological vulnerability, and how much is directly attributable to the availability of resources, to policy, and to the comprehensive management of what we know is a treatable viral infection?
The disparities strongly suggest that the burden of this dual diagnosis is heavily skewed by our failure to implement effective treatment strategies everywhere, and that's a factor that needs immediate and critical focus. You should continue exploring how specific viral infections can create these compounding long-term health risks.